guidelines. So with that in mind, we feel really privileged to be facilitating this conversation and privileged to also have you join us today as we discuss. Smiles for Mothers specifically is a collaboration with the government of Nigeria with funding from MSD for Mothers that seeks to reduce maternal mortality, but specifically looking at the lens of PPH and what we could do in terms of innovations for improving PPH care in our facilities. And of course, as part of that is introducing new and lesser use commodities, but then also ensuring good quality uterotonics are available at our facilities. As you know, every day we're losing almost 800 women across the world due to complications of pregnancy and birth. A lot of these are occurring in developing countries such as Nigeria, where we work. And at the same time, important to call out that these are not just statistics, right? For every mother, for every daughter, for every sister and friend we lose, it's not just an absence, a void in the family and community, but it has serious economic implications and just leaves a cost that is too much for us to bear. So on today's webinar, right, is more than just having experts and stakeholders speak, but really a platform for us to get to collective actions and shared lessons on how to use the best practices that we're learning from all the experts speaking to know what we can do better as we make tangible strides to address maternal mortality. These insightful discussions, experiences, opportunities that you hear about on the webinar from our partners is already part of a growing momentum that we see among actors, in the space towards scaling sustainable PPH interventions. I think one of those was the launching of the WHO roadmap for PPH, which was done last year, and an excellent way to also get us all coalesced around this agenda. So I encourage you all to participate. Please feel free to join us through the chat, send in your questions. And at the same time, we're also extending that gratitude to our esteemed speakers, too many of them to mention, who will be contributing today. So once again, welcome to the session, and thanks for being part of this important deliberation. Back to you, Lola.
Thank you so much, Uche. So yes, would like to know who is on the call with us. So please feel free to drop your name and introduce yourselves in the chat box. So up next, we're going to watch the explainer video for the Smiles for Mothers playbook. Just to give some background, Uche already spoke about the Smiles for Mothers program, where we've been working with the Nigerian government and state governments of Kaduna, Kano, and Lagos for the past 3 years. And our goal has been to reduce postpartum hemorrhage by adopting and implementing the 2018 updated WHO recommendations on uterotonics for PPH management. So our work on Smiles for Mothers has involved, updating required policies, strengthening the supply chain systems for uterotonics, and introducing heat-stable carbetocin for PPH prevention as recommended by the WHO for settings where the quality of oxytocin may not be guaranteed. So we're also focused on capacity building of, healthcare providers on the proper use of uterotonics for PPH prevention, and educating women in the communities on spotting danger signs during pregnancy. So the program put together a playbook, which essentially summarizes the successes and challenges that we faced while rolling out the WHO recommendations in Kano, Lagos, and Niger states. And the playbook was endorsed by the Nigerian Minister of Health, and it serves as a guide for others that are aiming to embark on maternal initiatives and other initiatives that are aimed at reducing PPH-related deaths. So the video gives an overview of the playbook. So if you can play the video now.
Did you know that Nigeria has a high maternal mortality ratio of 1,047 deaths per 100,000 live births, with postpartum hemorrhage (PPH) as the highest contributor? The leading cause of PPH, uterine atony, responsible for 63.6% of PPH cases, is preventable with active management of the third stage of labor (AMTSL) by using uterotonics like oxytocin. However, The quality of oxytocin is often compromised due to improper cold chain storage from erratic power supply, weak refrigeration infrastructure, and knowledge gaps among health workers on its storage conditions. In 2018, WHO updated its guidelines on uterotonics to include heat-stable carbetocin (HSC) for PPH prevention, addressing the fragile cold chain infrastructure in struggling health systems like Nigeria's. In 2020, the Smiles for Mothers program, with funding from MSD for Mothers, supported the Federal Ministry of Health to roll out these recommendations and drive HSC adoption in Lagos, Niger, and Kano states. These experiences are now detailed in our playbook, designed to guide healthcare stakeholders to improve maternal health initiatives. The playbook offers insight in planning, policy review, supply chain, sustainable financing, service provision, demand generation, and client's journey. By leveraging on the playbook solutions, the Smiles for Mothers program hopes to prevent tragedies due to PPH and ensure that no woman has to die while giving life. To scale up our PPH interventions in your state or to introduce a new drug or product in Nigeria, download the playbook using the link on your screen. Let us make a difference in maternal health together.
All right.
Thank you.
Good.
Thank you so much for the video. I think the link to the full playbook. So we have the full playbook available on. Like I said, it's a very important and very useful tool. So we'll go right into the presentations for today. We're going to have our first presentation. And I would like to introduce Dr. Gallos, who will be taking us on an important topic on the implications on new and lesser used medicines from the network meta-analysis on uterotonics for PPH prevention and the emotive study. So Dr. Gallos is a medical officer at the WHO's Department of Sexual and Reproductive Health and Research. Previously, he was a professor of obstetrics and gynecology at the University of Birmingham, UK. At WHO, Dr. Gallos also leads large-scale research projects and guideline development in maternal and perinatal health, focusing on intrapartum care, postpartum hemorrhage, and preterm birth. We're delighted to have him with us today and share his insights. Dr. Gallos, over to you.
Thank you very much. I'm able to screen share from my side.
Yes, you can.
Okay. Okay, are you able to see my screen?
Yes, we can.
Yes.
Okay, so I'll be talking about postpartum hemorrhage and about the uterotonics for the prevention of postpartum hemorrhage, about the emotive trial that was looking at the early diagnosis and first response treatment for postpartum hemorrhage, and then how does it all come together in the PPH roadmap published by WHO recently. And the reason why this is very important is because maternal mortality, we're far away from our target. And not only we're far away from our target, even though there was some improvements in the years before, the latest maternal mortality estimates show that, there has been stagnation in the last 5-10 years. So we really need to step up our efforts. And postpartum hemorrhage is the biggest contributor to maternal mortality. So it does make sense to streamline a lot of our efforts on postpartum hemorrhage first. So what WHO did, and that was a few years ago, used the evidence synthesis on uterotonics, was relying on a network meta-analysis. And that's a sort of a new way of looking at the evidence that it's out there, because there are around 200 randomized trials available looking at how does one uterotonic compares to another, or placebo, or no treatment. But there was no single analysis bringing it all in one and telling us actually, which one works, which one doesn't work, and which one is the best to use. So WHO used that evidence synthesis to produce recommendation to answer exactly this question, what works in terms of uterotonics, and if there are multiple ones that work, which one to select. I won't go to the specifics. I only have a few minutes of time, but I just want to show you how this comes to implementation. And after reviewing all the evidence and coming up with a recommendation, what was recommended practically is what you see in the screen. So if you do have skilled health personnel available and you do have oxytocin and that is of sufficient quality, then you use oxytocin intravenous if there is intravenous access, or intramuscular. If you don't have skilled health workers, you can use misoprostol, 400 to 600 orally. But if oxytocin is not available or it's not of sufficient quality, then you have other options that you can use. And that's either heat-stable carbetocin, ergometrin, synthometrin, or misoprostol. Perhaps an important asterisk here is that if you do have issues with the quality of oxytocin, and especially relying on cold chain, then ergometrin and synthometrin that contains oxytocin is unlikely to be useful in that regard. So you are left with heat-stable carbetocin and misoprostol. And carbetocin was found to be as good as oxytocin. Meanwhile, misoprostol, oxytocin remains superior to misoprostol. Interestingly, from the study that was conducted from carbetocin, from the CHAMPION study, comparing quality assured oxytocin to carbetocin, we've seen that even though with very good quality uterotonics, there's still many women that suffer postpartum hemorrhage. So in that study, around 15% of women had postpartum hemorrhage, so close to 1 in 8. But it was also interesting coming out from the study is that many women did not even receive any treatment. So what you see here in the graph is the blood loss that women had lost in the study, and how many of those actually received treatment with uterotonics. Conventionally, we say PPH is at 500 mLs, but at 500 mLs to 600 mLs, only a quarter of women had received any treatment. So a lot of these women don't receive treatment. And even with 1,000 ml of blood loss in the study, there were still 30% of women that did not have any treatment. And if you put that together, you will find that, half of the women that had postpartum hemorrhage, so 500 mLs of blood loss or more, did not actually get treatment. And that goes down to a missed diagnosis by the providers. So what we wanted to do with the eMotive trial is to see if we can improve on that. And the other problem that we also wanted to improve on is the sequential treatment. So WHO recommends that if a woman has a postpartum hemorrhage, you should actually do several things together. You should massage the uterus. You should also give a uterotonic and tranexamic acid. Examine the woman, obviously stop the bleeding, and intravenous fluids. They're all shown to be effective in the context of PPH. But what happens is providers often try one thing, see if that works, and before they try another thing, and so on. So during this time of assessing if the bleeding stops with massage only or with oxytocin only, there is more time being lost while the woman is bleeding. So what Emotive was trying to do is really condense these times. So if we were to make the diagnosis earlier, and when we try to start the treatment, we actually use all the effective intervention all at once. And then if that doesn't work, then we quickly escalate to second line of treatments, see if that makes any difference. And the difference that it made was quite huge. So there was 60% reduction in the outcome of severe postpartum hemorrhage, so blood loss of 1,000 ml or more, laparotomy for bleeding, and maternal mortality for bleeding. So that dropped from 4.3 to 1.6% with Emotive. And you can see here with the graph, there was sustained drop over time with Emotive. So every month, as people were learning how to early diagnose postpartum hemorrhage and treat it, they were getting better. And most of these improvements came because they were diagnosing PPH much better. The control, the usual care group, who found the same thing that was found also in the Champion study, that only half of them received treatment, that they lost 500 mL or more. Meanwhile, in the Emotive study, almost everyone received treatment. And again, they also comply with the bundle. So they had actually almost all the effective interventions. So for all women who had a postpartum hemorrhage. And now it's about how do we bring all this together. So we know we have effective uterotonics that work for the prevention. We know a better way of diagnosing postpartum hemorrhage and how to treat it. So we really need to think about how do we bring these things into one and implement them successfully. So WHO hosted a summit in Dubai of 140 participants from the ministries of health of high burden countries. There were 20 Ministry of Health participating in that convening, researchers, the industry, professional association, donors, and NGOs, and the UN agencies. In terms of deciding, what should be the agenda now moving forward, still, what are the research questions that remain unanswered? How do we really streamline our recommendations and our normative work? And how do we overcome some of the implementation bottlenecks together with advocacy? And that resulted in a roadmap on how to combat postpartum hemorrhage. It's been published by WHO a few months ago now. And there are ongoing efforts for implementation. Some of the recommendations included in that roadmap. That's all from me. I have said a lot. There's much more detail, obviously, in the published documents. I have put a few of them here if you want to read more about it. Thank you very much.
Thank you so much, Dr. Gallos. I think what we can also do is perhaps put the links to the published documents in the chat box so that participants can have access to them. So everyone, if you have any questions for Dr. Gallos, please put them in the Q&A box and he can address them while we take other presentations. Just so for the sake of time, I'll quickly move on to the next speaker, who will be taking us on a recap of one of the studies that was conducted, and her name is Sarah Rushwan, who is the project manager at Concepts Foundation. Sarah leads and supports advocacy initiatives for maternal health projects, emphasizing sustainable access to quality assured maternal health commodities in low and middle income countries. In addition to her advocacy work, Sarah manages implementation pilot studies and supports research and innovation projects within the organization. She holds a BSc in pharmacology and a PhD in immunology from King's College London, as well as an MSc in public health from the London School of Hygiene and Tropical Medicine. So we're thrilled to have Sarah with us today to share her insights on the cost of poor quality uterotonics to health systems. Over to you, Sarah.
Thank you, Lola. I believe you will be sharing the slides. Yep, great. Thank you. So I will summarize the findings of a model developed via a collaboration between Concept Foundation and the University of North Carolina to demonstrate both the health and economic impacts of substandard uterotonics on preventing PPH and reducing maternal mortality. Next slide, please. This was a 2-year multi-donor project, which is anchored in the principles of universal health coverage and the Sustainable Development Goals. So little evidence exists on the economic threat that substandard uterotonics pose. Hence, our objective was to build the evidence base on the need to safeguard uterotonic quality with the goal to help drive policy change. We developed a decision tree model for 3 country case studies in Nigeria, Ghana, and Senegal, and I will present the results summary for Nigeria. Next slide, please. So our study modeled the prophylactic use of uterotonics among pregnant women during the 3rd stage of labor, and this diagram presents the model flow. So we estimated the annual number of pregnant women, the probabilities of place and mode of delivery, and we ensured to capture heterogeneity across the population based on the demographic characteristics you see on the screen. We used targeted literature reviews, results from the emotive trial in Nigeria, and also engaged with key opinion leaders. So all of these were fed into the model inputs. Next slide, please. Moving on to the results of the model. So this is a summary of the results from the 8 scenarios that were modeled for Nigeria. So the top 7 scenarios all result in cost savings with use of quality uterotonics, but with differing assumptions. So I will just run through some of these scenarios and the related cost savings. So if all births happen in Nigeria, in facilities where only quality assured uterotonics were used, it could result in an annual saving of $197 million. Also, using a combination of quality assured oxytocin and misoprostol produced an economic saving of $187 million. Making a switch to using heat-stable carbetocin in facility births demonstrated a cost saving of $175 million. And also using quality misoprostol during home births could potentially save $160 million annually. And in the scenario where births taking place at facilities use quality assured uterotonics, there's an estimated total saving of $130 million. Conversely, if substandard uterotonics were used and all deliveries happened in facilities in Nigeria, the total annual expenses would increase by $73 million. Next slide, please. So the key findings from the Nigeria model show that savings in healthcare costs from using quality uterotonics could result in a saving of $89 million in Nigeria. And this includes savings on out-of-pocket costs, as well as long-term productivity losses. The model also showed a reduction of 75,000 PPH cases and 1,500 maternal deaths in Nigeria. So it is clear to see that substandard uterotonics burden the health system. And this is the first study to formally quantify the clinical outcomes and costs of postpartum hemorrhage in a UHC context in Nigeria, as well as the role that substandard uterotonics play in these costs and outcomes. So we can conclude from the findings that ensuring the quality of uterotonics would improve maternal health outcomes and also result in millions of dollars in cost savings for the government and families in Nigeria, as well as aid in advancing country efforts towards achieving universal health coverage. Next slide, please. This study has been submitted to a peer-reviewed journal for publication, and we will inform you once the paper is published. Thank you for your time and happy to answer any questions. Thank you.
Thank you, Sarah, for the very insightful presentation. It's good to see the results from Nigeria. Perhaps before we go into the Q&A chat box, I'd like to ask, so from the study, has it or how will it inform, policies and practices for PPH prevention in Nigeria?
So as I said, I think it will really bring out this economic argument that I think hasn't been investigated thoroughly. So it will help bring in that perspective so that it's not, so it's that we think of it in two ways. It's not just about, of course, it's about saving lives, but there's an economic component as well and a cost effectiveness element when we invest in quality assured deuterotonics. So through doing cost effectiveness analyses and modeling different scenarios, it will help with presenting governments with potential kind of forecasting strategies to take forward. So that will help with driving policy change in the future.
Thank you so much, Sarah. So if you have any questions for her, please put them in the chat box and she'll be available to answer them. So with that, we'll move to our first panel discussion for today. And I'd like to introduce our esteemed panelists who will be speaking to us about insights and experiences on the topic of the country experiences from Nigeria and Kenya on introducing new and lesser used medicines for PPH prevention. So on the panel today, we have Madam Ekaite Okono. She's the reproductive health coordinator from Akwa Ibom State Ministry of Health. She brings a wealth of experience with over 30 years in the reproductive health sector as a registered nurse, midwife, and public health nurse. She has served in both rural and urban health facilities across Akwa Ibom State in Nigeria. So currently, Madam Okono holds several key roles in Akwa Ibom State. She's the secretary of the state MPCDSR steering committee. She's also the state coordinator for the Community Health Influencers and Promotion Services, that's the CHIPS program. And that's in addition to her role as the Safe Motherhood and Reproductive Health Coordinator for Akwa Ibom State. So joining us alongside Madam Ekaite Okono, we have Dr. Iwaimi Ann Francis, who is the Reproductive Health Coordinator in Delta State. She has been a dedicated advocate for reproductive health rights for over a decade, leading various impactful initiatives in this field. She offers very unique perspectives on the introduction of heat-stable carbetocin in Delta State. Our third panelist today is Hajia Ramatu Jibrin. She has extensive experience in the reproductive health sector as well, with decades of work as a midwife and public health nurse. Her career spans both rural and urban health facilities across Kano State, Nigeria. Currently, she serves as the maternal and child health coordinator for the Kano State Ministry of Health, and she'll be bringing very valuable insights into today's topic. And finally, we have Michael Muthamia, who has more than 14 years of experience in implementing reproductive health programs across public and private sectors. And in recent years, he has centered his efforts on implementing the latest WHO recommendations for PPH prevention and management through the Smile to Mothers Kenya program, and also the AMPLI PPHI projects at Japaigo, Kenya. So we're delighted to have our panelists with us today. Let's dive into the session. We also invite you to please engage with the panelists by dropping your questions in the Q&A box. So yes, let's get into it. We'll start with Madam Okono. Good afternoon, ma'am. So we'd love to learn about Akwa Ibom's experience with introducing heat-stable carbetocin. Specifically, how did you leverage training programs for healthcare workers to facilitate the adoption of HSC for PPH prevention? Over to you, Madam Okono.
Thank you very much, and good morning once again. Good morning, and thank you for having me. I stumbled on a newsletter from Smiles for Mothers on the internet, and I read through it, and I saw their area of work that is majorly on the reduction of maternal mortality. So after reading through, I observed that they have an essential commodity that can be used to prevent and also manage postpartum hemorrhage. So I responded to the newsletter. And then, like a few weeks after, I was invited to a webinar. And thereafter, I had an invitation to attend a one-day workshop at Abuja, where the 3 pilot states, Niger, Kano, and Lagos, shared their testimonies on the use of heat-stable capitocin. I was so thrilled to the point that I had to ask them when they will be coming down with the scale-up so that other states may benefit from this essential commodity. So I was contacted by Ms. Sophia, and we talked at length. At the end, we had a training on MPCDSR in my state, as maternal, perinatal child death surveillance and response. So a team came, a doctor and a representative of the Smiles for Mother, and did a presentation on the use of heat-stable capitocin to prevent PPH and to also manage PPH. And then estimation of blood loss was demonstrated during that training. It was a 2 hours presentation, which after the Smiles for Mothers donated 100 ampules free of heat-stable capitocin to my state at the training venue. And so we shared this commodity to the high volume delivery secondary health facilities in the state, about 9 of them. And so from the testimonies on the use of this capitocin at the facilities where they were shared to, I have one here that a woman had a blood loss of 1,500 and was given a dose of heat-stable capitocin 100 microgram, and the bleeding was controlled. Another one happened in another facility where a woman had a blood loss of 1,000 mils and was also given a dose of heat-stable capitocin. And this is very, very rewarding to know that there is a particular commodity that can serve the lives of women in the communities. And so we would like the heat-stable capitocin to come into Akwa Ibom in a higher volume, not just the seed donation that we received. Thank you. Over from me.
Thank you so much, Madam Ekono. I think I have a follow-on question, but I want to go on to Hajia Ramatu Jibrin. Hajia Ramatu Jibrin, could you also please share with us about the experience in Kano State? So elaborating on the specific policies that were enacted in Kano that facilitated the introduction of heat-stable capitocin. So how did this policy support, training of healthcare workers and just ensure a smooth procurement process for the medication?
Thank you very much, and good morning. Thank you for giving me the opportunity to be one of the finalists. Actually, what the policy enacted in Kano that facilitated the introduction of heat-stable capitocin is the inclusion of the heat-stable capitocin into essential medicine list at national level, which was also then adopted at the state level. And a plan was made for the quantification, forecasting and supply for uterotonics through the drug revolving fund, which is the DRF that we have, into the annual operational plan, and other activities of training the procurement officers, the logistics officers that we work with the with heat-stable capitocin. All these activities were included into the annual operational plan. Another thing is the review and update of the life-saving scheme manuals by Federal Ministry of Health, where the state later adopted, and this enable the effective training of healthcare providers. The life-saving scheme manuals of doctors, nurses, and midwives. This review enable the effective training of healthcare providers with the updated document and for very best practice. I think this laws helps in improving the services and the utilization of the health stable capitation. Over.
Thank you so much, Hajia Ramatu. It's great to see how Kano State is using HSC for PPH prevention. Just to emphasize that heat stable capitation is for the prevention of PPH, not for the treatment.
Yes, it's prevention, sorry.
Yes, perfect. So we'll go on to the next panelist, Dr. Waimi Francis, to tell us also briefly about the journey of introducing heat stable capitation to Delta State. So if you can elaborate on the strategies that was used by Delta State in procuring HSC ampules and rolling them out to healthcare facilities within the state. Thanks, Dr. Francis.
Okay, good afternoon, Lola, and good afternoon to everybody on this call. The journey for the inclusion of cabotegravir into Delta State's essential drug list and the distribution started a long time ago. A couple of years ago, when the NPCDSR committee was inaugurated, the then chairman of the committee began the sensitization of the use of cabotegravir, especially with regards to how oxytocin distribution and storage was an issue in Delta State. Fast forward to last year and the year before that, when we began engagements with LifeBank. LifeBank brought the option of subsidizing cabotegravir. I think one of the challenges that we had at the time was the high cost of cabotegravir, and that a lot of patients were compelled to pay out of pocket. And so when LifeBank came to Delta State and we began engagement, this was an exciting new opportunity for us, and we wanted to utilize it to the best of our abilities. And so we, together with the LifeBank team, spoke in earnest and developed an advocacy plan where the LifeBank team, as well as the reproductive health team, scheduled and went for a couple of advocacy visits to the Primary Secretary of Hospital Management Board, to the agency, which is the Primary Healthcare Development Agency in the state, and then, of course, to the Ministry of Health. And after that, we went to the agency that is currently in charge of procurement and distribution of medication in the state, which is known as the DRF, the Drug Revolving Fund. And from there, everybody felt like we needed to come together to have a stakeholders forum where all the critical stakeholders would be in one room and discuss the gaps and challenges and how we were going to catalyze this opportunity as soon as possible. And so that was what we did. We set up a date and then we had the stakeholders meeting and everybody was on board. We discussed all the issues. LifeBank made several presentations where research on cabotegravir was dissected and presented to the House, and questions were asked, and a plan was developed. Going forward, we met with the Agency for Drug Distribution, and a proposal was sent by LifeBank. Following that, the state procured 500 vials of cabotegravir, and are currently working towards procuring more. After that, just before the procurement, LifeBank came into the state just because we needed to ensure that healthcare workers, the sensitization and demand for the medication among doctors, nurses, even pharmacists would increase. So we had a capacity building session that cut across the states. And then we trained healthcare workers on the just generally on obstetric emergencies and the use of cabotegravir. And this greatly increased the demand for cabotegravir. And we've had a lot of success stories going forward over.
Thank you so much for sharing the experience in Delta State. So we'll quickly move on to the final panelist with Michael Muthamia. So Michael, can you please share key insights gleaned from the Kenya experience with adopting and rolling out HSC for PPH prevention?
Yeah, so thank you very much for this opportunity. And Kenya has been privileged to get support from MSD for Mothers and United to introduce the WHO recommendations on PPH prevention and treatment. So we've learned that introducing a new medicine in the public health sector is not easy. It requires a lot of coordination and support. So when WHO released the recommendations of 2018, it was our responsibility to create awareness among decision makers so that they can be able to see what is happening at the global space. So the Ministry of Health required local evidence to be able to make a decision on whether to adopt the WHO recommendations or not. So we got an opportunity to implement the Smart Mothers project in 40 facilities across 10 counties in the country. And when we got this evidence, one of the first steps that we took was to disseminate these results to key stakeholders at the national level. As a project, we didn't share the results ourselves. Actually, we allowed the users to share the experience. That is when they shared that 90% of the providers felt that each carbetocin is easy to provide and it gives very strong contractions. And from that meeting, the ministry made a very bold commitment to scale up utilization of each carbetocin. So the next question was, what quantities do we need for the country? So we supported the Ministry of Health to come up with the quantities they require for this medicine across the country. We could not quantify for each carbetocin only, but we had to quantify for all PPH prevention, health product and technologies. And during that quantification exercise, the Ministry of Health made a very bold commitment that 60% of PPH prevention should go to each carbetocin, while the 40% would go to misoprostol and oxytocin because of the great results and great experiences that were shared by mentors. So the next step now was making sure that we institutionalize the product within the key national policy documents. So we made sure that the Kenya Essential Medicines list is updated. We made sure that the national guidelines are updated with each carbetocin. We made sure that the national training package has each carbetocin as part of the options, and we also updated the job aids. After that, now we started the advocacy process for procurement of each carbetocin by the national supplier, which is Kenya Medical Supplies Authority, and they used the quantification report to justify for direct procurement, because for you to procure directly, you need to have a justification. So they used the quantification report to justify for procurement of 360,000 doses of each carbetocin to the public sector. And the advocacy effort was led by the Ministry of Health. So once we shared our results, the Ministry of Health became the advocate for this product. And our plan now is to retrain our healthcare providers so that they can be able to use this product safely and make sure that the product is also available at counties. So we're also doing some advocacy. So beyond the public sector, we also reached out to the faith-based institution, which get their health product technologies from MEDS, a mission for essential drugs and medicine. And they've also floated a tender for around 50,000 of each carbetocin doses so that they can be able to supply the faith-based institutions so that we can take a total market approach for the country. So that is our experience. I believe I'll share more in the next question.
Thank you so much, Michael. I think my question for you and other panelists, so I'm going to give each person like 1 minute to speak about a key lesson that was learned during this rollout that you think any state or country that wants to also adopt and roll out the guidelines, what they have to bear in mind and what they would need to apply. So I can start with you, Michael. What's the key lesson that you would like to share?
Yeah, so the key lesson for me is health system thinking. For you to introduce a product, think about it in a broader scope. For example, you cannot talk about Eat Stable Carbohydrates alone. You need to think about Eat Stable Carbohydrates in the context of the entire PPH landscape. Think about, especially at this point, you need to think about PPH prevention in the context of the emotive, in the context of anemia, so that you're talking about the entire list of products. You cannot push one product. And then number two, institutionalize everything, make sure the policies, the guidelines are up to date. And then number three, make sure that you really do quantification, because the country needs to know what they require. And then think about the total market approach, both the public and faith-based. And then advocacy is really key. You cannot do it alone. Put all key stakeholders on the table so that you can be able to advocate and really move things together, speak in one language. And for Kenya, we've actually developed a PPH strategy refresh for the country and developed a costed implementation plan to look about, to think about PPH across the continuum of care. So prevention and treatment. And so that would be my recommendation, that think about Eat Stable Carbohydrates in the context of the broader PPH strategy.
Thank you so much, Michael. I totally agree with that. Yes, we have to think in terms of the big picture, and we definitely cannot do it alone. Dr. Francis, what would be the key lessons learned from Delta State's perspective?
Thank you very much, Bella. I completely agree with Michael. You need to take a holistic approach to the introduction of a new drug. It's quite challenging, especially in the context where you need to bring everybody together. But for me and for Delta State, advocacy is key. Getting all the stakeholders, the critical stakeholders together, letting them see, of course it's evidence-based, so let them see the research, let them see the work, let them see the result, and then let the work itself speak to the good things that can come off of inclusion of this. For us, we already have this in our essential drug list. So getting all the players on board, a total market approach also is essential. And of course, letting the people themselves make decisions, so inclusion of not just the medical or health sector, getting all those critical stakeholders, market women, the communities, the leaders, the elders, the religious bodies together, and let them see the benefits again, and then advocacy. Thank you very much.
Thanks, Dr. Francis. Hajiya Ramatu Volcano, what would be the key lesson learned?
Thank you very much. For the key lesson learned, I think it's almost the same, because for Kano, we use a human-centered design approach to get the key stakeholders buy-in on what we are going to do regarding the new drug that comes in, and getting their buy-in help immensely in improving the uptake. And because we sat together, we identify our challenges, we come up with the solution together, and we implement together. That really helps in achieving the utilization and the increased uptake of the drug. So not only Eat Stable Carbohydrates, whatever you are doing, we learn from the polio eradication, where we engage key stakeholders, where we engage community into the health system. This actually helps in improving. Also, whatever you plan to do, make sure it appears in your annual operational plan. If you have it in your annual operational plan, definitely you follow it up and make sure that things are done the right way it should be. And the way we look at things together, we follow up, we supervise, and we use evidence to make an informed decision. So these are key lessons that we learn from the utilization of heat-stable carbetocin. And like I've said, with the evidence that we've seen, where a woman come to deliver in the health facility, in one of our health facility, a gravida 4 with a previous case of postpartum hemorrhage, all the 4 PPH that she has to a non-pneumatic anti-shock garment has to apply to that woman. But with the coming of PPH, when she comes to deliver her 5th delivery, actually that should act as a wonderful things, because even the husband knows that she must have what do we call it, non-pneumatic anti-shock garment applied to her. So he was ready. He came in with the donors for blood transfusion, and he was the one saying it out that this, my wife, you have to tie her up, because he doesn't know the name. But he said whenever she delivers, she has to be tied up. So with the heat-stable carbetocin, when she came to deliver her 5th delivery, to his surprise, when this heat-stable carbetocin was given to that woman, she was the one that came out to come and see him with her baby. So that man was really surprised and really thanking the state for having that heat-stable. So it's an evidence to show. So, and we need to have a kind of knowledge management where we'll be sharing information to others so that you have a peer-to-peer learning. And I think these are a few things that I can say regarding the lessons learned.
Thank you so much, Hajara Matu. I agree so much with the human-centered design, keeping in mind, in designing initiatives, let's have the woman in mind. So we'll move over to Madam Okono to share her, lesson learned from Akwa Ibom State. Madam Okono, I also want you to just clarify, because while you were speaking, you had sort of alluded to the fact that HSC was used for treatment, but HSC is for prevention. So I'd like you to clarify that, and then also speak to, or maybe not correct that, and then speak to your lesson learned.
Okay,
Madam Okono,
thank you. Thank you very much. Actually, the mentioning of how carbetocin was used to manage that PPH is because it occurred at the time that commodity was in the facility. So it was used to manage that particular one. But for other ampules that were donated to the states, they were used to prevent the occurrence of PPH. I hope that is okay. So for the lessons learned, we realized within the states that we didn't have enough to go around the health facilities, especially the facilities in the remote areas, the communities where we have high volume deliveries also. So the state needs to procure heat-stable carbetocin. A process came into being. We had to involve the Honorable Commissioner for Health, the Director of Public Health, and also the Director of Pharmaceutical Services met with the Commissioner to see how we can bring in heat-stable carbetocin into the essential drug list for Akwa Ibom State. So we are waiting for the domestication of the national EML so that we can do procurement on the heat-stable carbetocin, so it can go around all the health facilities in the state in order to prevent maternal mortality, that is the avoidable deaths that occur. So, and also funding and procurement are major issues, which I hope now that my commissioner is involved in it, this will be taken care of. Actually, last year, when I was doing my work plan for my unit, I included heat-stable capitation as one of the essential maternal commodities that will be procured as supported by UNFPA. So that has been taken care of. And then for the state work plan, capitation, heat-stable capitation was included as one of the essential commodities to be procured within the state. Thank you.
Thank you so much. Yes, thank you so much to our panelists, discussing their experience with introducing heat-stable capitation for HSP prevention. I think we have an opportunity to take just one question from the participants. So if you have a burning question to these panelists or the previous presentation, you can quickly raise your hand and we'll take the first person that raises their hand. Sorry, the first person was Mashood Lawal. So if you can have, give access to Mashood Lawal to please speak and ask this question to the panelists.
Okay, thank you. Good afternoon, everyone.
Good afternoon.
Good afternoon.
Okay, please, my name is Mashood Lawal. I was the Director of Food and Drug Services at the Federal Ministry of Health between October 17 and October 2020. I want to it's good to have all the necessary medications for an improved outcome, patient outcome. But I want to sound a note of warning, given my experience with misoprostol. When it was promoted, it is good to, what I want to advise that we should do an extensive advocacy among prescribers and policy makers. We should not just go ahead to procure it without creating a demand gradient for it. The then minister, when the Minister of Health, when Professor Preston came up, they directed the procurement of thousands, tens of thousands of this misoprostol. But there was no demand in the various institutions that we use it. So we ended up throwing away those drugs. So that is my caution, my note of warning to everybody. Thank you.
Thank you so much, Mr. Mashood, for your comment. Just to say that in the case of heat-stable capitation's introduction in Nigeria, it wasn't, it was a careful introduction of heat-stable capitation. We worked with federal government and the state governments of the 3 states where we were implementing, and even the health facilities. And it wasn't just about updating policies. We also did some work around training healthcare workers on its appropriate use, and also worked with the communities to educate women about PPH prevention. So it was a very holistic approach that we took in introducing heat-stable capitation. And I think it was Haji Aramatu that also emphasized that in Kano and even across, the program states, the approach for implementing and rolling out these recommendations was really centered around like human-centered design, where we captured voices of women and the stakeholders in this whole PPH prevention journey to ensure that the initiatives that we were rolling out across our program states were the ones that were required to meet the needs of the women, were the ones that were required to meet the needs of our health care workers, and also to just help us progress in our journey towards reducing PPH incidents. So thanks for your comments. I think with this, we can move on to the next panelist. So we have another panelist discussion. So this is the second panelist discussion for today. And again, we have very distinguished speakers who will be speaking to us about the opportunities to facilitate the adoption and the use of new and lesser used medicines for PPH management in Nigeria. So the first panelist is Nanma Kankum, who co-leads the supply chain workstream on the Smile for Mothers program in Nigeria. He has over 5 years of experience in clinical pharmacy, health system strengthening, and program implementation. As a pharmacist and health management consultant, Nanma brings a unique set of skills and knowledge to the table. In his current role as the supply chain co-lead on the Smiles for Mothers project, he offers technical assistance on policy adoption and supply chain management for essential commodities, helping to implement WHO recommendations in the program-supported states. So we're excited to have Nanma here today. Next, we also have Ms. Dinev, with over 40 years of experience in developing and managing projects in international development, particularly in health and other program areas. Ms. Dinev brings a wealth of expertise to our session today. She holds an MBA, a gender diploma, and certificates in project management, monitoring and evaluation, and quality assurance. And she currently serves as the Regional Service Senior Advisor to FOROLAC and the MHA's caucus under the Secretariat of the Reproductive Health Supplies Coalition. We're honored to have Ms. Dinev with us today. So we'll start with Nanma, who will be taking us on a presentation to discuss the lessons learned and the opportunities from the Smiles for Mothers program. Over to you, Nanma.
Thank you very much, Lala. Please confirm you can hear me.
Yes, I can.
Okay, great. Thanks everyone for taking time to join us this afternoon in Nigeria, morning, wherever you are in the world. Thanks to the panelists too. I think they've made the work very easy for me. They've touched on the different lessons that I was planning to share. And really the other part of my presentation is about the way forward. What do all these lessons from the HIC rollout mean for the emotive bundle, which Dr. Gallos presented on earlier. So if we can move to the next slide. So while the Smiles for Mothers program adopted a comprehensive system strengthening approach to our PPH work, a key part of that was the HIC rollout was hinged on 3 critical areas. One was the policy updates, so creating an enabling environment for the commodity that involved working with the Federal Ministry of Health and State Ministries of Health to update the essential medicines list, to also incorporate plans into the state annual operational plans like Hajaramatu spoke on, but then also working with the Federal Ministry of Health to update the training protocols for clinicians to ensure that the commodity was included in the curriculums for healthcare workers. The second bit was really around the product itself. So establishing the supply chain for histobacterial and integrating it into the existing supply chain mechanisms within the states we supported. And that, on one hand, involved working with the suppliers to get regulatory approval for the product, but also getting it imported in country so that there will be available stock. Also then working with the states to forecast their needs for the commodity, ensuring it was integrated in their supply systems for last mile distribution to facilities. I think overall for this, we also had sustainability in mind. So one key thing we did was ensuring the rollout of the product was through drug revolving funds in the states. So states were able to generate additional funding for procurement of the commodity. The last bit, the last critical area, of course, but not the least, is the provider training angle. So to ensure that healthcare workers have the right knowledge and skills to use the commodity. So we did this through comprehensive training, so to try didactic sessions with demonstrations, practicals, but then also with mentoring routinely to ensure that the knowledge gained in class were still adhered to in the facility. So all of these lessons or these critical areas, we see how they have applications for other new and lesser used commodities for maternal health, but also specifically for PPH. Specific examples will be tranexamic acid and calibrated drapes, which are not new in all cases, but are lesser used to a large extent. So if you take a snapshot of the Smiles for Mothers states at a time where capitation rollout has been done across these three critical areas. If you take tranexamic acid, for example, where though it's included in policy for use for PPH treatment, the current approach is one where it's used in a stepwise manner, which Dr. Carlos sort of touched on. But I'm also aware the Federal Ministry of Health is currently updating PPH guidelines to recommend its use as part of a comprehensive bundle. So there's an opportunity within the states and for other players who want to do this work to update policies to replicate the current global recommendations. For the product angle as well, tranexamic acid has been available for a while, but its demand is quite low. And we see how that ties in also into the limited provider awareness of the recommendation to use tranexamic acid for PPH management. So to improve this, there needs to be a lot of training, a lot of awareness, things that we touched on about advocacy to also come into this to ensure that these commodities are available. So as a program, we see how focusing on these critical areas can facilitate the introduction of these other new and underused commodities for PPH management and especially the bundle items. However, one thing that has proven to be a challenge over time has been the financing angle of it. So whether that's financing for the product, also even getting resources for training healthcare workers. And we see, as some of the panelists even spoke to in the previous session, how collaborating to find opportunities within the current system would help to just solve some of these financing shortfalls. On the next slide, which is really the last slide I have today, is really calling out some of these financing structures, some of them government and established, but some also new and donor-led. So among the established funding sources, we see how drug revolving funds are very important and very widespread in Nigeria. So usually operated by drug management agencies to ensure there's a sustainable supply of essential medicines. So for the new commodities or the lesser used commodities, we see how channeling these products through these systems would lead to a sustainable supply for them. Health insurance schemes are also very good platforms to use. So where enrollees are offered services at subsidized cost. So we see how that has stimulated use of stable capital and has potential for other commodities. Another option is free MSH programs, which are run by states. Important to call out that they have some largely had sustainability challenges where there's not really a plan to ensure it keeps going. But we've seen some states put in creative measures, so trying to allocate funding from like their job revolving funds to continue to have funding flow into their free MSH programs. So it might not be the number one funding source, but it's something that's available to especially help women who are not able to pay for their care. In terms of the newer funding opportunities, we want to spotlight two. One is the Catalytic Opportunity Fund, which is managed by RHSC and also CHAI. And this fund aims to catalyze investment in innovative health initiatives. So funding from the COF can be used to introduce new and lesser used medicines like tranexamic acid and also stable capital, and it also can be accessed by states and national governments. The second one I want to also touch on is the UNFPA Supplies Match Fund. Through this funding stream, UNFPA provides matching funds to governments to procure and distribute essential maternal health commodities. In this case, tranexamic acid, capital, oxytocin, and also misoprostol. This is also a very important stream because how it operates is for every dollar a government spends in procuring quality commodities, UNFPA would match it with $2 worth of products. So we see how this has the potential to increase government spending, but also increase the procurement of quality products, because the products that would qualify for that funding stream need to be of good quality. So I would pause here. I think the next presenter will touch a bit more on the Catalytic Opportunity Fund. But thank you so much for listening. Over.
Thank you, Nanma. If you have any questions for Nanma, please put it in the chat box. After the next presentation, we'll go into a Q&A session where the presenters will be able to answer the questions. So at this point, we'll just go over to Ms. Dinette.
Thank you so much, and thank you for inviting me today. My name is Milka Dinev, and I work for the Reproductive Health Supplies Coalition. So good morning, good afternoon. I'm on the other side of the world, so
So just checking, did we lose her? Okay, seems like we've lost her. Okay, Nanma, while we wait for Ms. Dinev to come back, there's a question in the chat box around the availability of HSC and also the affordability in country. So would you like to answer that while we wait for her?
Yes, thank you, Lola. I'm happy to. So yes, heat stable caryotidine is available in country, supplied by IDA Foundation, who are the market authorization holders. So they are in charge of getting it to the states or to any procuring entity. So it's available once the supply needs to be made, it can be made. We have a fact sheet we would put in the chat box so that you can access for any additional information. In terms of the price, at this time, I can't say what the specific price is, but it's the last time the state bought was about 1,400 naira per ampoule. Okay, I see Milka is back. I'll just wrap up and hand over to you. Thank you. So yes, it's available, and that's the current price of the product. Thank you.
Thanks, Nanma. I think we have Ms. Dinev back. Please can you
yes,
confirm
and I am so sorry. I'm in Antigua and Barbuda. It's an island in the middle of the Caribbean, and doing work here, but connection is really bad. I'm sorry. Let's go to the next one. So I was telling you that this Catalytic Opportunity Fund is directed to local entities that are willing to scale up the use of heat-stable carbetocin for prevention of PPH, as well as the use of TXA for the treatment. The projects need to catalyze introduction and scale up of these two medicines and focus on prevention and treatment. Only treatment is not eligible, so it has to be done both things, prevention and treatment. It has to align with government priorities, and private commercial sector scale up is not eligible. This is eligible only for the public sector scale up. Next. Oh no, again.
We can actually hear you.
You can? Okay.
Yes.
I'm going to stop the video. Maybe that works. Okay.
Yes.
So the COF needs government endorsement. So any entity that submits an application has to have government endorsement and a very good plan to train and scale up the use of heat stable carbetocin and TXA. Also, it is important that the product is already in country, because there's no use in training hundreds of providers when the product is not available. So the product has to be available. And the activities and learnings will be integrated into government activities through the development of the National Implementation Plan. So we are giving preference to those activities that can catalyze additional resources and link to other previous PPH investments. Next. The emphasis is on preparatory activities that support accelerated introduction and scale up of the use of heat stable carbetocin and TXA. These eligible activities are forecasting and quantification, LMIS inclusion, training of
Okay, it seems like we lost her again. While we wait for her, Nanma, there's some questions for you in the chat box. Do you want to unmute and respond to them?
Hi, Lola. Yes, thank you. I think I would just do that. Yes, thank you for the question. I think I see one on the new and lesser used commodities fund. I think that's a great point. Yes, it's also an option for procurement. As a project, we've also tried to support some of the states we work with to access the new and lesser used commodities fund. Important to call out that there's currently some confusion about who can actually access the fund, whether it's a national government or a subnational entity like the state. So that's something we're also trying to clarify, but it's also and I know UNFP has committed to providing some clear guidance on those very soon. But so that's also a good option to look out for in terms of procurement. Thank you for calling that out.
So the Catalytic Opportunity Fund
Milka, are you back? No, she's not back.
We are focusing on my internet is super unstable. Yeah. Yes. I'm so sorry.
Well, we can hear you now. Let's try it again.
You can hear. Okay, let's go to the next one. And Sean, if I drop off, please, you continue. There's 2 more slides to go. Eligible countries include low and lower middle income countries as designated by the World Bank, and where the Ministry of Health has included both heat stable carbetocin and TXA in its essential medicines list and in their clinical guidelines. At this time, we have about 18 countries where heat stable carbetocin has been registered. So these countries are all eligible to come to the Catalytic Opportunity Funds. If the organization includes activities not supported by our fund, we will need to have them cost share those activities. Next slide. The project duration must be for 6 months to 1 year, depending on each proposal. Final report has to be submitted no more than 2 weeks after the project ends, and the maximum budget is 100,000 per country and 250,000 if it's a multi-country proposal. No one entity can receive more than 250,000 per year. Merck for Mothers will participate as a voting member with equal weight on the expert review panel, and we have several volunteers that have an expert review panel with us. The next one. Yes, and I'm ending with this quote that you can see. It's a basic healthcare necessity, and I encourage people to write to me and approach the COF, as we will be more than happy to entertain your applications. And I'm so sorry for my connection problems. Thank you so much.
Thank you so much for the presentation. Yes, we understand the connection problems. If you have any questions for both Nanma and Ms. Dinev, please put them in the chat box. Perhaps, I don't know if your internet permits, Ms. Dinev, to also please talk about, I mean, just for the folks on the call, the timeline and the process for submitting a proposal.
The call for applications is open, so you can submit your applications now. We have several applications in the pipeline. We have been working with the applicants in improving the quality of their application and also in ensuring that there is a stock of heat-stable carbetocin and TXA in the country. So that is an important element in the application process. But the applications are open. We are receiving them, so please do. I see that Jeff Jacobs has included the website where you can find more information and where you can submit the proposals. And we're extremely grateful to the generosity of FCDO and Merck for Mothers for this activity. And we're looking forward to receiving applications from all these countries where heat-stable carbetocin has been registered and could be made available.
Thank you so much. Nanma, I see you're typing the response to one of the questions in the chat box, so please type and just respond in the chat box, because we just have 2 more minutes. So I have to wrap up. We have to just go to the wrap up and next steps. So just before we conclude on today's webinar, again, I would like to thank everyone for their participation. I'll say I've sort of jotted down some of the key takeaways from this webinar. First is we've learned about successful strategies and approaches from around the world for managing PPH, including the adoption of new and lesser used medicines, heat-stable carbetocin. Our speakers today shared very valuable insights and lessons learned from implementing PPH programs in various settings, highlighting both successes and challenges, also highlighting their journey in introducing heat-stable carbetocin for PPH prevention. We also discussed opportunities for scale-up, opportunities as well as the funding opportunities that are available. We discussed strategies for scaling up the new and lesser used medicines for PPH management, considering all the factors, the regulatory approvals, supply chain management, policy advocacy, and things like that. We also talked about the importance of collaboration. We cannot do it alone. We have to engage with other stakeholders across sectors, and also just leveraging existing networks can help us facilitate the implementation at scale of this new and lesser used medicines. I think one thing that I'll also like to emphasize is the importance of data and evidence. So it's important to gather and analyze data, to understand the effectiveness of the different PPH prevention strategies, because using evidence-based practices helps to guide decisions on, the rollout of the medication. Also, we cannot overemphasize the importance of investing in training of our healthcare providers, which is very key to ensuring successful implementation of new medications. So we hope that today's webinar has provided valuable insights and it has inspired us to advance PPH management efforts in our respective contexts. I'd like to thank our speakers, our panelists, and of course the participants for your very active engagement. I'd also like to thank the organizers. I'll say let's continue working together to make meaningful progress in reducing maternal mortality due to PPH. Thanks and bye-bye.
Bye-bye to everyone.